So, good afternoon, everybody, and thank you so much for coming to this final section and for keeping strong here towards the end of the day. I hope you had a really wonderful day with a lot of interesting discussions, and I hope we can finish strong for this first day of the conference. So we are here to present this symposium, and we have tried to make it very much an interactive symposium on learning interprofessional collaboration during clinical supervision, the potential of workplace dialogues. So first of all, I want to hand over to Dineke to introduce herself.
Hello, my name is Dineke van Asselt. I'm a medical director and geriatrician, and I do research on learning how to collaborate for residents in Nijmegen, the Netherlands.
Yes, and Martin?
I am Maarten van der Ven. I am a geriatrician as well, and I'm also a PhD candidate in the field of interprofessional collaboration learning in the workplace and a teaching ambassador for the Radboud Teaching and Learning Center.
And my name is Maria Louise Gambau. I'm an educational psychologist from Danish School of Education in Aarhus, Denmark. And I'm going to be the moderator today. So first of all, we don't have any conflicts of interest in regards to this session. And just quickly to go over the content of what we're doing. So we're going to start with this introduction, which we are doing at the moment. Then we want to discuss or present and discuss the impact of increasing complexity in clinical practice of learning. As you may have seen in the abstract, this is a quite important key part of our presentation. Then Martin is going to present on how we learn inter- and intra-professional collaboration in the workplace. And we're going to finish off by talking about how can we do this through learning dialogues. And we are presenting for 10 minutes, and then we have 10 minutes for discussion, actually. So keep in mind or keep questions close to heart. So if you have specific questions for each session, then you can post them either on the Q&A in the app or in the room, and we have microphones running around. Not the microphones, but the people running around with them. All right, so first of all, for some definitions, we want to start off with defining some of the constructs, and I'm going to hand over to you, Martin, for the first part.
Thank you. In literature, there is a distinction between inter- and intra-professional collaboration. For this symposium, we're trying to take a little bit of more of an overview from both perspectives. But just as a starting point, here you can see the definition and the differences between the two. In interprofessional collaboration, it is the topic of collaboration between healthcare professionals with different backgrounds. So these can be nurses, physicians, physiotherapists, or speech therapists working together from one integrated treatment plan. While in intra-professional collaboration, it is discussing the collaboration between professionals with the same background but different specialties. So these could include geriatricians with surgeons and general practitioners working from one integrated treatment plan. For this symposium, we will use them interchangeably, but in literature, you will see them both.
Great, thank you, Martin. And let's get this ball rolling. So, first of all, what we are talking about today is workplace-based learning. And to set off this symposium with a common knowledge, one thing is knowing what do we mean by the different definitions, but also what is it that we actually mean by workplace-based learning. And there was a great paper published a couple of years ago that tried to conceptualize what are the characteristics that go into workplace-based learning. So they said that there can be specific learning tasks, there could be individual characteristics that have a play into workplace-based learning, and then there is the learning environment characteristics that play a part in how we learn during our working hours. And this learning environment characteristics is what we are specifically talking about today, because what Pilgrim et al. Discussed was that this was support from supervisors and co-workers. This could both be peers and non-peers. it was team learning climate, and tolerance of and feedback on failure. So the two things that we are going to talk about today is specifically the support from supervisors. So that might be you, it might be you in the future, or you might be a student receiving the supervision, but also how do we support this team learning climate that we will that comes from this supervision. And the reason that we took a point of departure in the supervising strategies is that there is a lot of actors across these learning environments. And when we talk about learning, we often think that learning happens at a certain time and needs certain characteristics and certain mechanisms to actually be driven forward. However, learning takes place all over the place. And there's a lot of actors and there's a lot of mechanisms that go into it. So this is one of the studies that I did where we tried to explore where does learning actually happen. So it happens in the office, it happens in the patient room, it happens in the dining room, and it happens in the hallways. So when you go to work, you are learning every second of the day. And what was really interesting to see is that supervisors are present in all of these spaces. So supervisors are actually incredibly important for this learning environment. And then in terms of dealing or talking about what is it that we actually mean by supervision, it has had a multitude of different wordings around what is it we mean by supervision. Some say it's feedback, mentoring, coaching, guidance, or preceptoring. What is it that we actually mean? And for that purpose, we can divide the purpose of supervision into three. It can be normative, so that is to monitor or evaluate learning, to support continuous development. It can be restorative, so when something negative happens or when there's failure involved, it can be to support learners' professional and personal well-being. And then it can be formative, so to develop and guide learners towards their professional development and practice. And towards the goal, there can be two types of supervision. There can be the clinical supervision, which is informal and continuous, or there can be educational supervision, which is a formalized practice. This can take place in the clinical workplace, but it is formalized and it has a set time and place, whereas the clinical supervision typically is informal, ad hoc, and happens all the time. So, as Corbin and Faber said in their article, they defined it as supervision or informal as supervision between a resident and a senior physician who is not the resident's formal supervisor or a situation that is not formally organized. That is the type of supervision that we're talking about today. So now I want you to do a quick reflective exercise with you. So you're going to get 30 seconds for each step of it, and I'm going to guide you through it. First of all, I want you to look back. Think of a supervising moment where collaboration across different professions or perspectives played a role. What made it work well and what made it difficult? And talk to the person behind you or beside you or in front of you. 30 seconds. Go. All right, so it's a Spitfire reflection exercise. The next one, I want you to look inward. When you supervise or receive supervision, how do you model or encourage collaboration across professional boundaries? Is there a particular habit that you use or could use that make this more visible? And I'll give you 30 seconds again. All right. And for the last part, you need something to write down with, because now you're looking ahead. What is one opportunity you have that you see to strengthen the interprofessional collaboration or learning through your supervision in the near future? So what is a next step that you could do that maybe help this? And you're going to use this at the end of the presentation as well. So write it down and I'll give you 30 seconds to do that. And it's really good. I'm really glad to hear you talk with each other. I want you, if you want to, I would encourage you to share your looking ahead in one sentence within the live chat, and then we'll come back to it at the end. But for the next part, Dineke is going to take you through what is complexity.
What is complexity?
What is complexity?
Good afternoon. I want to tell you about one of my residents. She's on call in the ER and she's admitting an older woman. She's 84 years old with dementia. And she's suffering at the moment from heart failure and kidney failure. And after a recent she was admitted before with a hip fracture. She lives alone at home. She has home care for about 20 minutes a day. Her son lives 2 hours away, and she's on 14 medications. The resident is making a plan how to treat her heart failure, is looking at the meds, what can I change, and is wanting to admit this patient. But then reality kicks in. The cardiologist wants to change the diuretic therapy. The nephrologist doesn't agree. The son is angry because he feels that his mother was released from hospital way too soon. And then the nurse from the ward is calling the resident and telling her that the patient is becoming more and more agitated and looks delirious. This resident is living the complexity. And there's no guideline to tell her what to do. There's no right answer here. And this is my question. Do we train our residents to work in this complex world? Then I have to change the slide. And this is exactly what Frank and colleagues more than a decade ago warned us about. They said that if we keep training health professionals for a world that is neat, predictable, we are setting them up for failure. And they urgently called for a transformation in medical education, from fragmentation to system thinking, from routine competence to adaptive expertise, and from working alone to working across professions and sectors. And while Frank told us why we need to change medical education, Lucy painted a picture of how this future would look like for physicians. She said we need to change to move from the personal, expert, sovereign physician who's autonomous, independent, and accountable mainly for his knowledge and care, to a collaboratively active systems physician who is interdependent and accountable for patient outcomes and also care outcomes across the boundaries. And when we talk about complexity, it's not a buzzword. It's more. We can measure it and we can study it. So let's go back to the year 2002. I was 23 years younger. I had just finished my PhD and residency and started working in a large community hospital as a geriatrician. The typical admission was elective. It was challenging but manageable, and patients were younger. They had fewer conditions, fewer medications, and their care was much more straightforward. Now, fast forward to 2017, and look what's happened. We see more older people with multiple chronic diseases, with 10 or more medications, who arrive by ambulance in the ER, and they have several acute problems at the same time. And this is not a subtle shift. These are real signs of complexity. And what does that mean? It means that in every day we are caring for patients who are sicker, more fragile, and require coordinated and integrated care. And it means that the skills I had in 2002 are not longer enough in 2025. And it's not just the patient who has become more complex. The whole system, the whole ecosystem has become more complex. New technologies are really nice, but we have to keep learning. I'm learning now how to use ChatGPT. Yes, I am. Medical knowledge is growing fast, and it's not possible to stay on top of every new thing that is about. Disease patterns are changing with new diseases coming and going. Think about COVID. The workload is increasing while staff is getting shorter, more shortages, and patients' and families' expectations are growing. And on top of that, we have financial pressures. There is no more money. We're on a tight budget. So complexity is real. And when we talk about complexity, we talk about complex systems. And complex systems have several features. Like, for instance, the butterfly effect. Something small, like a missed call to a patient, or changing something in a medication, or a delay in a lab result, can have big results, effects, and most of the time we didn't expect that to happen. Other things is that complex systems adapt. A new team member joins and dynamics change. A shortage of IV liquids, like we had recently in our hospital, changes how we have to treat our patients. Complex systems have feedback loops. Some are reinforcing, others are balancing out. And this makes systems unpredictable, and they evolve. And understanding these characteristics is no longer optional, but it must be the foundation on which we design care and education. But here's the thing. Humans don't like complexity. We are not wired for complexity. We like things to be tidy, like a checklist, check the box. But a hospital ward is anything but a tidy box. It's a living and breathing organism. A single delay in radiology can put off a whole discharge plan and another patient can't come in. A nurse calling sick will change the medication round, patient flow, and even family meetings. And what we do is we try to fix things by not in the system, but in isolation. So let's fix the discharge process, or let's work on medication safety. But it's important to look at the whole systems instead of trying to solve parts. We're living in complexity. We don't like complexity, and we don't teach complexity. Medical education in the university is foremost based on reductionism. And that means that everything is linear, stable, 1 + 1 is 2, and predictable and measurable. But that doesn't apply not totally anymore, because although it's comforting, it's not real life. And if we go about that, whoa, it's like trying to take the cat apart and to understand what is a cat. But meanwhile, our residents are facing this complex care environment. And they experience an increased mental workload. They have a sense of loss of control. They are troubled by the bureaucracy, and they feel they have no time to do things right. Hidden in that mess are powerful benefits, like strengthening your personal identity or deeper learning, and it can stimulate adaptive expertise. But the problem is, in the moment, the burdens outweigh the benefit. And that's when you hear the residents say, "I'm finding this difficult." And here's another question. Does competency-based medical education really prepare our residents for the complex world they are working in? Competency-based medical education is what Frank and colleagues proposed in 2010. And whilst CBME has given us structure, clear milestones, and defined competencies, it works beautifully in stable, predictable situation. Because it measures often isolated skills. It assumes a linear progress, and it trains for parts, not the whole system. And that leaves our residents walking a tightrope over uncertainty, wondering, am I really ready for this? And that's a good question, because up to now, there's no evidence that it does. We don't know if it prepares our residents, and we don't know if it improves patient care. And then the question I have is, what kind of practice are we training them for? Is it a personally expert sovereign physician, or is it a collaboratively active systems physician we are preparing them for? And this mismatch is not just uncomfortable, it's costly, because if we keep teaching for order and certainty, we leave our residents underprepared for the uncertainty and complexity of real patient care. But there's something we can do, and that's at the workplace. This is what we do. We don't acknowledge complexity, we train for it every day. We teach all Dutch geriatric residents about systems thinking, clinical uncertainty, adaptive expertise, and how to learn at work. We run learning models for geriatric residents, nursing home and primary care residents, how to work together across the boundaries. And our supervisors, they get the same training, because if they can't coach complexity, they can't model it. And in our daily care practice, we use a structured format for complex clinical decision, so we make care and training happen side by side. We prepare our doctors not just to survive complexity, but to lead in it. Medical education, in my opinion, moves at the pace of a snail. It's only 7 years ago that we implemented CBME in the Netherlands. And already I feel that we're lagging behind. The gap between the speed of change and the pace of our adaptation is what I call the adaptation lag. And this means missed opportunities, poorer care, and burned out residents. If we want our residents to thrive in tomorrow's complexity, we have to close the gap now. And what can you do in your workplace? Remember the resident caring for the patient with heart failure, recovering from a hip fracture. She tells you that she finds this case difficult. This is code for complexity. If somebody tells you, I'm finding this difficult, it is complex. And what you can do is help the resident deal with complexity. Name it, make it explicit. Ask, what's about this case is complex? And model it. Think aloud, show your reasoning in trade-offs in uncertainty. Address the emotions that come with the clinical uncertainty. And use it. Turn the multiple perspective, the cardiologist and nephrologist, and say, how can we weigh these? And reflect on it. Pause after a complex case to ask, what did we learn here? Complexity isn't failure. We have to teach residents how to live it. And if there's something I hope you take away today, is complexity is not the enemy, it's the reality. And we teach in tidy boxes, but our residents practice in tangled webs. Let's give them the skills to navigate uncertainty, the courage to collaborate, and the insight to see the bigger system at play. And this way, we become educators who are relevant to health. Thank you. So here's a sum up of the conclusions. Yeah. And now we can have our group discussion. How are you currently addressing, or maybe after this talk, going to address complexity at the workplace? We have microphones, which is great. You can also use the swap card. Is there anybody who has a question or a remark? Yes, please.
Great, thank you very much. Very interesting talk. You spoke about preparing trainees, the residents, for this complexity and also preparing their supervisors. But you also spoke to the interprofessional nature of the clinical learning environment, and I'm wondering if you can speak to how you prepare, engage the other members of the healthcare team in that environment as well.
We do that. Thank you for your question. What we do is we have discussions about complex patients. Maybe when something went not quite as we wanted them to go. And we invite the nurses to join this conversation. We also address it at our multi-professional team meetings, where we try to give multiple perspectives on the patient case. So that's how we try to do it with our geriatric team. Yes?
Sorry, can I just do a quick follow-up? Yeah, I mean, I appreciate that kind of collaborative approach to addressing patient problems. I guess just thinking about how they might be essential to more integration into the educational process and maybe in a more formal or being fuller members of the teaching team as opposed to only as part of the patient care team.
Yeah, thank you. There was a question.
A reflection on a challenge. In trying to, I do postgraduate education, so so into specialty training, and trying to get people to engage with learning in formal teaching about how to work with uncertainty and all the things you're talking about. is often met with boredom and disinterest because, and they're very explicit, the exams are assessment of what is known, not complexity, and they are driven by wanting to pass exams. So I would really welcome any reflections on that challenge or what we should be doing in that space.
Yeah. I really recognize what you're saying right now. So once a year, I teach every geriatrician in training in the Netherlands. And we talk about complexity and uncertainty and teamwork and decision making. I only had one resident saying, I don't understand why this is important or why we have to discuss it. So do it anyway, make it interesting, make it authentic. I have a case I use with which I struggled a lot. And I talk about it and I explain how I navigated through that case. And so far, knock on plastic, it went great. Okay, that's it. Yeah, one more question.
Time for more? Yeah. Okay, thank you for a great talk and references. I'm a GP, so I also live in the complex world, and I've been thinking about this a lot. At the moment, I mostly teach postgraduates, and they're quite motivated.
Yeah.
But the undergraduates, it's hard for them to understand the complexity, and I've been kind of thinking about, is it so that you have to be in the water to learn how to swim? Do you have to realize what it is? And I'd love to hear your thoughts about that.
Yeah.
How could we prepare them for the waters?
Thank you for that great question. While preparing this talk, I thought that the way Frank intended it and Lucy told us about it, it's they should learn about systems thinking. And so maybe not the complexity at the workplace, but what is systems thinking and what does it mean and how can they understand it. I have a minor for pre-master students. And they gave feedback to me and they said, you give this talk about complexity and it's something we don't understand. They gave me the tip, let us see the patients and then you can talk to us about the complexity because then we know what you mean. So I will be flipping the setup of that minor. So it's true, it has to be just in time. So we have to keep thinking about that, yes. Yes?
Thank you, Dineke, for your interesting talk. And I would like to continue with the second part of this symposium, where I'll be talking about inter and interprofessional collaboration learning in the workplace. As you heard in Dineke's part, is because of the increasing complexity, we see how particularly older adult patients have a growing treatment team. So there's more and more professionals involved in the care of one single patient. And we see that in order to prevent adverse outcomes, it is essential that these workers collaborate effectively to create coordinated and integrated care. And as medical education, medical educators and researchers, this has been a topic of research of the last years. We are, in our enthusiasm, we might create learning activities, formal activities to facilitate this learning. But when we do that, our residents and our interns will say, our curriculum is already so extensive, do we really have to do new things? Luckily, collaboration is mainly learned in action during participation in clinical practice. So we may need to find ways to learn collaboration during our clinical practice in the workplace. And so we have to find ways to incorporate it in our work. And there are theories that can help us identify these moments that may be valuable for learning inter- and interprofessional collaboration. The theory of boundary crossing is very helpful in that. In this theory, it is described that there are invisible and visible boundaries within clinical practice, and that our patients often cross these boundaries. These boundaries may be between disciplines, so between nursing and medicine, or between specialties, so between cardiology, pulmonology, and internal medicine. And this learning potential of boundaries can be identified in boundary objects, boundary workers, and boundary activities. Boundary objects are artifacts that have value in both sides of the boundary. So, taking an intraprofessional example, these can be discharge letters or referral letters that a GP sends to the hospital or the hospital sends back to the GP. Boundary workers are workers that work in both contexts and bridge the gap between the contexts. In my personal case, I am a geriatrician and I work in an academic hospital and in a psychiatric hospital where I can bridge the gaps between those worlds. And boundary activities are activities that occur around or across the border. In an interprofessional collaboration example, these could be ward rounds where nurses and physicians meet. So the learning potential of working around and across these borders can be found, boundaries can be found in objects, workers, and activities. These three phenomena are daily occurrences. They occur in everyday clinical practice. So you would say learning occurs in through boundary crossing. We don't have to do anything. Unfortunately, it is not that easy. Even though these opportunities occur daily, we do not learn adequate coordination and integration of care through these moments in clinical practice. Through inter- and interprofessional collaboration is not learned automatically, as is seen in the work of our colleague Natasha Lohman. So my colleague has explored how could we facilitate this? How could we make sure that inter- and interprofessional collaboration learning does occur during these moments in practice? And residents say, well, probably when I have these conversations, these dialogues with my supervisor, that would be the perfect moment to learn on inter- and interprofessional collaboration. But what do the supervisors say? Do you really have to learn collaboration? You do it every day. I am doing enough. I don't need to do anything more to facilitate learning inter- and interprofessional collaboration. And well, I maybe we can facilitate learning collaboration, but I wouldn't really know how to do it. I have no idea how to do it. This has been seen in both work in inter- and intraprofessional collaboration. To explore this, we have performed an ethnographic study where we observed dialogues between supervisors and residents in our department, and to see if during those conversations opportunities for learning intraprofessional collaboration occurred, and if there were any boundaries or anything, there were any barriers to this learning, so to see how we could facilitate it better in dialogues. After our observations, we performed interviews to explore their motivations behind the behaviors that we had observed. And during this study, we saw that resident and supervisor dynamics in the interactions hindered learning interprofessional collaboration. And these being the prioritizing monitoring over meaning making, the misaligned feedback intention and interpretation, and the entrustment struggle. So these dynamics seem to form barriers for learning collaboration in the workplace. Prioritizing monitoring over meaning making. When we observed interactions between resident and supervisor, we saw that these interactions mostly are focused at creating the right treatment plan and a diagnostic plan for the patient. So that took up the most of the discussions. Residents said, you need to perform tasks that require the approval or blessing of your supervisor. So we have to make sure that we discuss everything related to the diagnostic or treatment plan, and we'll see if there is some time for learning, but that's not my main focus. Supervisors agreed that monitoring of the patient, the care plan for the patient was the most important part of their supervisor dialogue, to make sure the resident knows if this patient does or does not have dementia. They said, well, if I'm finished with creating the treatment plan, maybe if we have some time left, we can go into more of a learning opportunity. Okay, so, and I explored with this supervisor, okay, and how does this relate to interprofessional collaboration? They said, well, I'm first focused at learning the medical technical skills, and then if we have some time left after that, we can discuss more about interprofessional collaboration. So in the lists of priority, it was creating the treatment plan. If there was some time left, I could give some explanation on why or whether or not we would want an MRI scan in the diagnostic trajectory of dementia patients. And if we then have some time left, we can talk about the informal caregiver system or case management or something like that. So that was the priorities that were set during supervision dialogues. In an extreme case, one of our residents said, I am just the slave of the ward. I just have to work, I just have to perform the tasks. I'm not here to learn, I am here to work. Learning, that is something for medical interns. I am a working professional. Another phenomenon that we saw was misaligning feedback into intention and interpretation. We observed how a supervisor wanted to provide feedback on the discharge letter that a resident wrote. When we interviewed him, he said, well, I was reading the letter and I thought, this is not clear for the general practitioner. He has no idea how we arrived at this conclusion. So this has to be made clearer. When we interviewed the resident, the resident said, well, I've learned that I have to be concise in my letter because the patient can read it and I can get a complaint from the patient. So these intention and interpretation were entirely different. When we explored this with the resident, they said, well, the intention of feedback is not always made explicit. So we get a lot of feedback, but we have to create our own interpretation of this feedback. It's not always clear what is meant by this. And when we discussed this with the supervisors, they said, well, if I start checking whatever I've given feedback on what the resident has learned, then I think they would feel very unsafe in our clinical teaching environment. So this prevented them from clarifying their feedback and their intentions behind the feedback. Another dynamic that we found was the entrustment struggle. Residents, at least in our hospital, are very prone on being able to autonomously work, to create a treatment plan by themselves, at least with the least amount of supervision needed. And the supervisor was also very keen on finding how to give the least amount of supervision, to give the most entrustment to the resident. And they were kind of keen on, well, I have to give supervision that is part of, that fits this resident, that is at the level of this resident. And when we explored, okay, so how does collaboration come into this? They said, well, the younger residents, they are so busy with finding out if the patient does or does not have dementia, I wouldn't go into collaboration. That's just way too far. Those more higher metacognitive aspects, they are not for the beginning residents, they are more for the more experienced ones. And when we interviewed residents that were more experienced, they said, well, collaboration is such a basic skill, I don't need any supervision on this. This is an entrusted activity. We do not have to discuss this. I'll just be nice to the GP and then I'll be fine. So there seems to be not a real good alignment between these perspectives on learning collaboration in the workplace. So how do these phenomena help us create opportunities for learning interprofessional collaboration in the workplace? These 3 tips we can distill from our findings. Discuss the daily boundary object activities and workers in the clinical supervision. Part of what I daily do is to create to paint the picture of how a patient in the other setting would go about. So if I have a patient in my academic hospital setting, I will say, well, in psychiatric care, they would do it like this and this. So I facilitate the boundary working aspects of my practice. That's something you can do in everyday interactions. These moments occur in almost all clinical supervision, and they don't need to last that long. In our observations, we saw that if you discuss this during your clinical supervision, there is not an entirely extended amount of time. These can be in the little moments in the daily practice. When you give this feedback, it can help to discuss how you've arrived at the feedback. We as supervisors tend to make bigger steps in our thinking, and to take a little bit of a step back and take some sub-steps, you can explain how you've arrived to certain feedback. We can help in the making visible what the trajectory of this feedback is, or how you've arrived at it, and what it means for the collaboration process. And the last one is for both. Allow yourselves the interactions between resident and supervisor. As entrustment and trusted professional activities are the hype of the moment, we tend to budget on our time between resident and supervisor. But this time is a learning opportunity which we can value and which we can use for also more metacognitive aspects of clinical practice. Hopefully these 3 tips can help you in your next clinical supervision. And then I would like to go on to the conclusions, which I've added on to the conclusions as presented by Dineke. Although plenty of opportunities occur, learning adequate inter- and interprofessional collaboration does not happen automatically. And the dynamics may provide barriers, but by being aware of these and making them explicit, we might find ways to overcome them. We would like to discuss with you on this topic: how can workplace supervisors facilitate learning inter- and interprofessional collaboration in clinical practice in spite of resident-supervisor dynamics? The floor is yours. Maybe there are something in the chat.
I'll start with, I think it's very different depending on your relationship to where you're trying to do it, and also your status. So if I look at the way I've done that through my career, it has varied from when I have been a junior consultant through to being a senior consultant, and then you get a prof next to your name and you look at totally different again. And the way you have to do it has to keep changing. So I think changing to match your relationship is really important.
I think this aligns with the presentation of Dineke. We as professionals are not done learning. We are learning throughout our whole career. And our relations with other specialties, other disciplines also keeps on changing. So we have to remain a reflective professional ourselves as well. And these dialogues with our junior doctors are very valuable to keep this learning process going. In geriatric medicine, we have a lot of general practice residents, elderly care residents. So these discussions, they teach us they keep on teaching us about how to learn collaboration all along our careers.
We also have a question down here. I can read it out loud. What is the definition for interdisciplinary collaboration? What definition of interdisciplinary collaboration would you uphold if different from IPC?
What is in literature you see different types of definitions. So there is interdisciplinary collaboration, there is interprofessional collaboration, intraprofessional collaboration, and I think from a theoretical perspective, in many of these settings, the boundary crossing theory is useful, because boundaries could also be clinical field and education or science or something. So these principles you can use, but collaboration among doctors is very different than collaboration among doctor, nurse, physician. So it's important to see how the context impacts these different types of collaboration. So power dynamics might be a topic that is very important in intraprofessional collaboration, which is entirely different in interprofessional. So I think the focus is on what process do you want to address, what are the players in your room, and clearly state which definition you use in your paper. So I think that would be my tip for that. In most of our focus has been in multi-morbid older adult care among doctors. So that's why we usually use the intra-professional collaboration in our studies. There is one over here.
Sorry, so it's along similar lines, but have you looked or have you thought about how you would bring in that interprofessional conversation in supervision? Because I think we've looked a couple of times at least getting sort of that 360-degree feedback from an interprofessional situation, and there's been quite a few barriers in terms of people feeling comfortable to give, feedback across, across like nursing to medical and medical to nursing in a collaborative, like breaking down that kind of wall. And I'm just wondering if you've looked at how, because I just wonder, having these conversations that are about collaboration with other teams, whether you ever bring those teams into those conversations about how you do it better.
That's extremely difficult. I think we are also still searching how to do this properly. We have made a program between our primary and secondary care residents that do a co-located rotation, and that facilitates the discussion because you're then all part of the same group. But in and out groups are a common phenomenon in inter and interprofessional collaboration. And usually the dialogue and also being reflective to yourself, like, okay, this is something I would like to learn about, may open the conversation with other fields.
Thank you for the great symposium. I have done research in interdisciplinary, interprofessional education and collaboration, and what I learned from that research and related to your comment before is hierarchies. I think for the physicians in the room, I don't think we realize the hierarchy because we are in the top of that hierarchy, but it's very impressive to see the difference in perception, the difference how other professionals feel less valued. And it's impressive to see, there is actually a lot of research when you go to the OR and you see, for example, the different levels of stress. And even, usually the surgeons are the most satisfied, and even within the discipline, the anesthesiologists are less satisfied. So it's more of a reflection that how can we improve? I think is to be aware of this, because actually I believe that most people are not aware. And then my barrier with my team, with the other professions, is the fact that I think our working rosters are quite different. And then sometimes, there is no motivations that, I don't want to be simplistic, but even if we talk about monetary compensation for a nurse, a technologist, a physiotherapist, a pharmacist, to stay the extra time to do the work. Sometimes, for example, physicians, we tend to do a lot of extra work, but sometimes that cannot be the reality for other disciplines or professions. Thank you.
Yeah, I think your remark is very valuable. We've identified learning opportunities within the discussions between resident and supervisor, and one of those was when some sort of a prejudice or some sort of ideas about the other professional occurred. These could be very between the lines, so they wouldn't be very explicit. But that is a very valuable opportunity to learn, why do you think that, and how do you think that would affect our collaboration? And by making those explicit, one can reflect on, hey, how do my ideas about this professional affect my collaboration with that person? A little bit of an example from my own practice. Geriatrician is usually not the most high in the hierarchy. And I was at a wedding with my partner, and someone asked me, what do you do? And I said, geriatrician. Wow, do you like that? That's impressive. So these kinds of ideas about each other can be reflected in what we say. So to be aware of how we see the others and how this may impact our ways of talking to each other is a first step in the right direction.
All right, and you will get the opportunity to ask more questions in a minute. But first of all, I've been given the opportunity to talk at the end of this, so I hope you are still awake, some of you. Because I'm going to talk a little bit more, go into depth with these dialogues, these supervision dialogues, and what do they actually mean, and how do we engage in them, or how do we approach them. So I talked about before what supervision is and how it can serve different purposes and what especially informal supervision it is. And we have done a little bit of research on how do we divide or how do we describe this informal supervision. And what we found was that it could serve two goals. So first of all, it could serve the goal of closure, which is or the goal of discovery. So closure is about clarifying information, and it's very important for productivity in the ward. Discovery, on the other hand, is more so towards prompting critical thinking and can promote this ability to adapt in new situations and engage with complexity. So if we go into depth with each of these two different kinds of supervision, closure is practice. What we saw was that closure is practices with instructional approaches deemed important for efficient and safe patient care. That means these are very important ways of supervising. This could be verifying information or a decision. This could be direct instruction or taking over. So when collaborating with your peers or with other professions, other disciplines within your profession, this can be extremely important, particularly in terms of when on the day is it in the middle of the night. This is a very important way of supervising each other. And this can also be something that you model towards learners. On the other hand, discovery is practices that reflect instructional approaches set to promote adaptive expertise. So this was the framework that we used in this study. This could be metacognitive instruction, helping to integrate conceptual knowledge with procedural knowledge. These are very big words. I'm so sorry. I will go down into depth with some of these in a moment. Creating productive struggle for the learner, which is actually really difficult for the learner. Orienting to new aspects of the case or shared discovery. So, what does it mean to supervise for discovery? If we take productive struggle, it is about asking the what-if questions, or about asking questions that prompt them to think on their feet. What can this tell you? What else could it be? If you want to instead try to have some sort of metacognitive integration, which would be the ability to actually think about the larger perspective, think about what is it that I need to learn from other disciplines, from other professionals. And it could be also a way of teaching students or learners to check in with themselves. If you feel uncomfortable with this decision, then you should do this or that. It is important that you see how the patient reacts to so and so before you do this and this. Or thinking aloud, model the behavior to the learner. Prompting conceptual understanding is a way of trying to introduce the broader perspective to the learner. Thinking about how do I expand their current knowledge about this problem outside of the procedure that they're going to engage in. And this can be extremely helpful if you want to engage with other professions, other disciplines. This could be teaching or saying something along the lines of patients with these kinds of symptoms are always indicative of so and so because, and that is the key word, because this and that. This is normal for a patient of this age because so and so. So trying to get the bigger perspective, get them model the behavior of actually engaging with the larger conceptual understanding of this construct or this problem that they're facing. And lastly, orient them towards novelty. Help them see their blind spots. This can be, have you looked at? Did you ask about? Did you notice if? These are types of questions that really help them broaden their understanding and find their own blind spots. But what we also know from the literature is that being a supervisor is a balancing act. So we saw closure and discovery was present in the supervision dialogues. But as supervisors, you need to balance, do I facilitate learning over patient care? Or are they actually something that could coexist? This article by Noble et al. Talks a little bit about how this is really difficult balancing act. And what they're saying is that supervisory knowledge emerges from the context of its production and is anchored in by and in supports by the practice. So not only is supervision something that benefits our learners, but being a really good supervisor is facilitated by the support in the context from supervisors' peers. So if you're a supervisor and you see your colleague actually trying to engage in very difficult supervision practices, encourage that, support that, or model it to your peers how to do it. Because we're talking about the either or, but maybe, just maybe, every interaction can be a teaching moment. But how? How can every interaction, I said this in the beginning, the fallacy of thinking that learning never at some point doesn't occur, that's a fantasy. Learning occurs all the time. So how can interaction be a teaching moment? There's a very recent article from last week by Miller et al. Who really showcases this in a very, very good way. And they say that interprofessional law, so the stories and Martin was also touching upon this, the stories that we are teaching about or telling about other professions, other disciplines, is what really helps learners engage with these professions. Sharing experiences with collaborating with others in supervising dialogues is really important for new learners or new residents or medical students in this case to be able to engage with other professions in their clinical practice. Here, supervisors and peers are role models for how to interact and react. So when you are engaging with another discipline or other professional from your own discipline, how you react to unwanted behavior, wanted behavior is something that you directly model to your learners. So it doesn't just happen in the supervision space, it happens outside of it as well. And linking it back to our study on discovery and closure, they also touch upon that supervision that prompts reflection, such as discovery supervision that I touched on, can help learners make sense of their own and others' experience. So one thing is that there's a fallacy about learning at some point that doesn't happen. That is a fallacy. That is a myth. So learning happens all the time. But to actually capitalize on that learning, we need to also engage in reflection. And Schön said this 100 years ago. We need to reflect in action and on action. And supervising conversations, informal, ad hoc, during the night or in the day, are key to actually capitalize on all these situations that can be learning opportunities. So, discovery learning is great and all, but it can be initiated by both parties. It doesn't have to be initiated by supervisors. It can also be initiated by the learner. But we need to be very, very mindful of how we're doing it, because especially the discovery kind of supervisions can be extremely frustrating for the learner, and it can create exam-like situations, and we don't want that. We don't want them to feel on the spot. So, building on the conclusions, establishing expectations early in these informal supervision conversations to foster psychological safety and set the stage for effective collaboration. And supervision is a dynamic shifting between structured closure and open discovery. So both of them can support learning in complex contexts. And here, daily dialogues in supervision promote interdisciplinary collaboration, encouraging reflection on both challenges and opportunities in these collaborative spaces. So, now we've relayed a lot of information on you, and we are nearing the end of this symposium. So first of all, I want you to build on the discussions you've had so far and talk about what learning activities are you implementing during clinical supervision or have experienced as a learner yourself, and how did they support learning interprofessional collaboration in complex clinical practice? And I'll give you 2 minutes to discuss with the person next to you, and then we'll take some questions. All right. I'm curious to hear what you have been talking about today. Questions, comments, whatever. What have you experienced as a learner yourself? Maybe? Or have you experienced something horrific? Or really great? Or, yeah, question down there.
Hi, this is not so much a question as it is an observation or a comment. I am a nurse, and it's really interesting to me, and I bring it to your consideration and the audience as well. Caring for patients not just requires that we all collaborate interprofessionally. I think I see it more as an interdependence with each other. We're educating our learners, and in the many cases you explained, you specifically spoke about medical physician learners, but I also wonder, in the relationship as a nurse with physicians, I find it also to be very much, like I said, interdependent. I rely on my critical thinking skill as a nurse to communicate to the medical team my observations of how the patient is evolving and changing, and the needs for adjustments. And I think in my time when I worked with residents, they also relied on me, especially when I worked the night shift. The first person that I would see at 4:30, 5 o'clock in the morning was that medical student who would come up to me and say, "So how did the patient do overnight?" And my information really provided valuable information to the medical team to decide what the plan of care is going to be for the remainder of the day. So I would like to get your thoughts on that interdependence, more than crossing a boundary, because even though we know the boundaries there, like the nurses are here, the doctors are here, the pharmacists are here, the physical therapy is here, but how do we rely on each other's observation of the patient to bring to that mutual knowledge and then co-create a plan of care? I think more than boundaries, it's about how I rely on my colleague from my other profession to build that knowledge and make better outcomes and treatments for patients. Thank you.
I think this might be more directed towards Martin, but I can, yeah, so.
Shall I answer? I think a key component of inter and interprofessional collaboration is the shared integrated treatment plan. We are all together responsible for one treatment plan. And what you see occur oftenly is there is a nursing plan, there is a medical treatment plan, there is a physiotherapist with its own treatment plan. But I think the basis is we have to create it all together, so we are responsible for it together. But in order to do that, I have to know what you do as a nurse and you have to know what I do as a doctor. So a very important part of interprofessional learning is role clarification. I think that's kind of the part which you're referring to. So that's one of the main topics you would like to address in these kinds of learning situations.
And also going back to the plenary yesterday, in terms of thinking differently about how we train our healthcare professionals. Do we want to train them together? So a lot of studies don't what's that called? Don't counter in that maybe we should, when we think about simulation training, maybe the learner is not only the resident, maybe it can also be the nurses. But having spaces also to apply for funding for doing that research is very, very limited. So I think it's a systems thing as well. We have a lot of questions. Yeah, Andrew.
I have the mic, so I'll pass it. So my name is Andrew. I know Maria, but I'm Andrew from Sydney, Australia. I'm a physician, but I'm married to a nurse, so I can comment, and also a supervisor. So I wonder if I could just foreground the basic assumption, which I maybe can't get the words right, but everyone is intelligent, cares about doing their best, and wants to improve. And I wonder, we've already heard in this conference many microaggressions towards non-physician professions. I think I just wanted to bystand to everyone in the room who's maybe not a physician that we are all in this together. I even heard before in this room that someone said that doctors are the only people staying back. I can assure you that nurses and other allied health professionals do stay back. But my question was, in foregrounding a basic assumption that we're all in this together and we're all trying to improve, how do you add that into the culture where perhaps that's not necessarily shared by everybody in the climate or in the landscape of practice? That's my question. Thanks.
So just to repeat the question, how do we engage culture to actually think about
how do we change the culture?
How we change the culture?
The basic assumption is held.
Yeah. So how do we change the culture to ensure that the basic assumptions about we are all in this together permeates?
Would I answer?
Yes.
Yes. Thank you for that the question. In our on our ward, we have this. We've working for more than 10 years about what do we mean by interprofessional collaboration. What does it mean to you as a nurse, to you as a doctor, etc. And we worked very hard to come to a shared mindset. And what we do now is that we start the day together. So doctors and nurses, the physiotherapist, the secretary, we all come together at 9 o'clock and we start our day together. And we talk about what happened during the evening and the night, how is that going to impact our working together today. And sometimes then when the nurse is ill or isn't coming, the physiotherapist says, well, I can weigh the patient because I'm getting her out of bed anyway. So that's stepping into what we can do together, because we are in it together, as you said. And that's the point. We want the best care for the patient, and that can only happen if we do it together. So no more the patient can go home because I am done. It means the patient can go home because we are finished as a team. And so once a week on a Wednesday, we talk about how do we collaborate. and it can be any topic, and it's the doctors and the nurses, and we come together, and this discharge plan didn't go how we wanted it. How do we communicate and collaborate? So it's us with the patient and their families who want to provide the best form of care. So we have a whole system in place to support that mindset, I would say.
And if I can just add to that, one of the things that was really powerful that I saw, it was the point about how important language is and how important it is to voice things as well. So some of the supervisors that I observed, which did a really great job of setting that standard for care and standard for collaboration, would voice, have you talked with the nurses? They know everything. And have you really building each other up? So being really mindful of voicing how we can build each other up, but also actually doing it. So actions speak louder than words. And some of the really great supervisors that I saw would then, if a resident or a learner came to them to confer about a patient, and they were like, I actually don't know, let's go ask the nurse. Then you can model the behavior of how are we in it together. So I think those kind of micro behaviors are really important in terms of changing cultures, and then understanding that this changes over a span of 10 years, maybe 20. And I just wanted to briefly for meta communication. So we're moving into the discussions part. So if you have questions regarding the entire symposium, this is also welcome now. And I don't know if we have online as well, so they can come up. But if we have any other in the room.
So thanks. My name is Tan Ching from Singapore. So I can sense that this is a fairly uni-professional way of interprofessional education in a complex clinical setting, and we are constrained by the way we practice. So I'm wondering whether we can look to the future where somehow our residents are taught by the nurses, by the physiotherapists, by the OT, either because the multidisciplinary round has that capability, or somehow our notes are now unified to have one care plan. So what is the future like? Because otherwise it's still very uni-professional in the interprofessional learning, and potentially we are still missing the opportunity.
I think Martin or Dineke, you.
Yeah, I think residents and interns look up to their supervisor in their daily practice. And one of the ways I try to incorporate interprofessional learning within these dialogues is to send them out and ask, what does the nurse think? What does the general practitioner think? And then that's not enough, because then they will go into either do it or don't do it, because sometimes it happens, sometimes it doesn't. But I also ask back, what did they say? Is this, does that work for nurses like that, or doesn't it? So also the following up on the things discussed in the dialogue can help to facilitate those conversations, because they will have the conversations with the general practitioner and the nurse and the physiotherapist, but do they engage in the feedback? And to send them out may help that. Yeah.
Thank you. I would like to add that the way Lucy saw the physician that we need. So the interdependent, we had heard this word before here, the interdependent system working physician. And that's, in my opinion, the only way forward. And that's what we have to put on the first place and dedicate every effort. We did observations of physicians in the ER taking care of an elderly patient with a hip fracture. And we were, how do we say, not very pleasantly surprised about the way they did not collaborate. They would sit next to each other, taking care of the same patient, not being aware of it, calling different oncologists for the same advice. And they came up with a totally different care plan. And this is the reality. And if we do research by surveys and ask, how did you collaborate? Oh, it was great and nice, and I could ask any questions, and la 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 la. But that's not happening in real life. We still train for the personal, expert, autonomous physician. And that's what we train them for. And we have to strip that down. We have to do it together in this complex world, and leading by example and showing them what we mean if we say collaborate. In the Netherlands, collaboration has a different smell because of the Germans, blah, blah, blah. But we don't have a good word. We say samenwerken, it doesn't cover it. Collaboration is much, much more, and we can't stop emphasizing what we mean if we say collaborate.
A reflection on the last comment or question. In Australia, the future is now, in terms of for the residents in their first 2 years of training will have to get a certificate of satisfactory progression, which has got EPAs in it, which can be signed off by different professions. So it's not a medical-only system. So the future is now. I think one of the interesting spaces there is, I think we have unspoken assumptions about what is appropriate in the way you have a supervision, informal supervision discussion that is quite different, just moving from one place to another, and definitely between different professions. And I think there's a skill in learning what is the appropriate way to do it as you move, and how do you find that out. And I'd welcome any thoughts about how we learn that skill, because I think it's a critical one if we're going to do this well.
So when we started with the PhD project of Maarten, we thought supervisors know how to teach collaboration. It will be easy. So we tell them about the module, and everything will go smoothly. And then we discovered that the problem isn't the resident, it's the supervisor who is closing the door, and not my problem. I'm not an expert, I don't know. So then we had to address the supervisor's reaction, and also in the ER with the hip fracture patients, the supervisors are somewhere else in the hospital. They don't know what's going on in the ER. And they say, don't call me unless there's a problem to the resident. So the resident fixes everything. And the supervisors, the surgeon or the anesthesiologist will say, I only hear about it when my treatment plan can't go through. So if the geriatrician objects, then there's a problem in the collaboration. But that's not the case, of course. We are collaborating, we have a different viewpoint. And that we have to discuss. So what is collaboration? How do we address it? I like your idea of getting a certificate that they give feedback. We have the same. We call it a 360-degree assessment or feedback form. But we have to teach the nurses, for instance, that they can give negative feedback because it's all very nice. Oh, he's a great doctor, blah, 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 blah. And they think everything is going great. So unfortunately, I think we have a long way to go.
Adding on to that, we lack a language to talk about collaboration. So the right words are often missing. In our observations in this study I've presented, many of the learning opportunities were not recognized. So we often don't see a referral letter as a boundary object. It is a way to summarize my work. It's not to follow up on for the next physician. So identifying what moments in clinical practice are actually collaboration is, I think, the first step, and then making them a topic of discussion besides, is this a sepsis, yes or no?
And there's a online question as well, I think that ties really nicely into that, which is how much should we formalize interprofessional supervision in order to foster a collaborative environment that encourages informal interprofessional supervision? And if I should just start by answering that, I think one of the things that we need to be mindful of is what the last paper that I presented in terms of how much is it that we actually learn supervising behaviors through our peers and how they support us in learning these behaviors. And I think we do have a lot of formal, especially or at least in Denmark, we do have a lot of formal training for supervisors. And I don't think necessarily that formalization per se, going back to EPAs for interpersonal collaboration, I don't think that they necessarily drives change. I think that there's a huge power in informal supervision and culture in terms of how do we actually support that. So how do we model it to our peers, these kinds of collaborative behaviors, and how do we model it to our the people higher up and the people below us and the people next to us and the other professions. Yes, I think we have time for 2 more questions. If there are anybody else in the room.
My name is Lina. I'm a trainee in general medicine, a family doctor almost. I feel like I do this all the time, every day. So I really have a lot of reflections on what you are talking about. But what I think is very fruitful is to just have a language for this, to recognize that this is a discipline, this is a competence. And we have done that in our curricula, so that's why it takes up a lot of time during our education. What we also do is we have supervision between the peers, and it's formalized with a supervisor who's superior. But we talk about complex clinical practice all the time, and in that you always meet some sort of interprofessional collaboration. And when you try, if you have to integrate more interprofessional collaboration, for me it's very helpful to take the patient perspective. Because when you think about the patient in the bed or in my chair, then you recognize, oh yeah, there is a cardiologist, there is some infection going on right now. And you start prioritizing, but you also really keep track on the patient who is, everything evolves around. Yeah. So just some comments, not really questions, but thank you so much for a very inspiring talk.
Thank you.
Thank you for that remark. That's actually something that we changed in our module. Because we are letting the physicians talk to each other. And then we said, let's talk about what does it mean for the patient if we don't collaborate. And that changes the perspective. So if the GP wants to get the patient into the hospital and we think, it's nothing medical, it's just a problem in the care. But when you put the patient center and forward, then everything changes because we all want what's best for the patient. So then it's no problem anymore. So thank you for your comment, very relevant.
And I think I need to close down the comments because I want to finish on time as well. So if you have any comments, we will be keeping tabs on the Q&A. So we will try to in some way respond if we can. Otherwise, we want to finish off with going back to the looking ahead. So if we zoom in on what you wrote to yourself in terms of what can I do, what is one small opportunity you have in your own context to do something different, or one small opportunity to capitalize on supervision, on interprofessional collaboration? And then how do you commit to one act you can do next week that works towards that goal? I will give you just 10 seconds to write that down or tell the person next to you what you want to do. Very quick writing. too. And with that, we want to thank you all for coming, for being here. It's the most disheartening thing trying to have a presentation and people walks out during it. So thank you for being here and thank you for staying also. Thank you so much to Amy, of course, for letting us come. Thank you to Cirkeline over here, who's a student helper who helped moderate all the comments. And this is our emails if you want to address some of these issues, if you have further comments. And then I have been asked to a kind reminder that there is a highlights video at the end of the session that you can go watch in the swap cards as well. Okay, it's here apparently. I don't know. I'm only a messenger. So thank you so much for coming and have a great evening.
Welcome to the AMY Conference 2025.
I love attending this conference.
We've started, and I'm sure it's going to be an excellent program.
Challenges are too complex to be solved by a single researcher or a single discipline, and that is what we are here to do.